description about electrolysis. Better than I can stand here and talk to you about. It's a good little rubric, or, yeah, diagram. So let's talk about the nursing management. You already did a little bit of nursing management when you found a collapse in the chair, right? Frequent turning and early mobilization. Anytime anyone's in the hospital, you get them moving as much as their physical condition will allow them to move. And if you are not able to get them out of the bed, you get them positioned in the bed to maximize lung expansion. And you tell them if they're laying there to clench their fists and wiggle their toes as much as they can while they're awake. Early mobilization and keeping clients in the bed as mobile as you can, given whatever their physical condition is extremely important. And if they can't move themselves, you as the nurse, you as the registered nurse on the unit, have got to make sure they're being turned no less frequently than every 2 hours. 2 hours is a maximum. If you can get them moving more than that, that's better. But at least every 2 hours. And, you know, you teach them strategies to improve ventilation. You teach them deep breathing exercises. So during waking hours, every time you go into the client's room, have you done any deep breathing? No matter what they're there for. If they're in the bed, they're at risk for atelectasis. Because do you stay in the bed when you're home? Say no. I'd like to be on my deck. Incentive spirometer. We all know what that is? That does helps expand the lungs. So every client who's bedridden for whatever reason should have an incentive spirometer at the bedside. And you as a nurse can do that. That is a nursing function you can do. You do not need a physician's order to get an incentive spirometer. That's a nursing function. So we also, we teach clients strategies to remove the secretions, right? We teach them to cough. Okay? And if we have someone who's had an abdominal incision or they've got any incision, then we show them how to splint. We show them how to hold a pillow across their incision, and we teach them to cough. And simply by saying, take a deep breath and go, sometimes you'll make them laugh and they'll cough. But if they'll do that 2 or 3 times, then they actually will begin to really cough. Just going is going to irritate the trachea a little bit and facilitate coughing. Because remember, coughing is a protective mechanism to get the stuff out. Awesome. We may use aerosol therapies. Most of the hospitals in metropolitan Atlanta have respiratory therapists who come and use the aerosol therapies. You'll have respiratory modalities on Thursday. We're not going to spend much time covering that here. But you may be in a clinical setting where you are as the nurse. When I first started, we didn't have respiratory therapy, and the nurses did everything. So there are aerosol therapies with medications that help expand the lungs and clear the secretions. And then we do chest physiotherapy. There is a very good picture of chest physiotherapy in your book. When you all cover cystic fibrosis with family health, you'll talk about that a little bit more. I'm not going to teach you how to do chest physiotherapy today. But it has to do with postural drainage. And simply by turning your patient frequently, you accomplish some postural drainage because you're helping those secretions move around. So in also preventing atelectasis, we want to use whatever strategies are available to improve ventilation and remove secretions. That's what we're doing. We're improving ventilation. What is ventilation as opposed to respiration?
The air in and out.
Moving air in and out of the lungs. Okay. We want to improve ventilation. We want to remove secretions. Now, what's important for maintaining thin secretions?
Fluid.
Hydration.
Hydration, exactly. So if we have a client who's got a high fever and they're not getting enough fluids and they have no appetite, we have to make sure they stay hydrated because the secretions will be thick and we will not be able to clear them. The client will not be able to clear them. As I said, on Thursday we're going to talk about respiratory modalities, and we'll talk about PEEP then, which is positive inexpiratory pressure and intermittent positive pressure breathing, and I should bring my CPAP machine, shouldn't I? Yes?
What is a BiPAP?
BiPAP CPAP is constant, and a BiPAP decreases the pressure as you exhale. Okay? With a CPAP, there's a constant, a small amount of pressure keeping the airway open, not the nose, but back here. Because with obstructive sleep apnea, what happens is the trachea, the esophagus, it collapses. And so what CPAP does, continuous pressure, just keeps a constant flow of pressure. And so you're exhaling against that pressure too. With BiPAP, if you have someone who's got some restrictions, they have some restrictive airway disease and they're not able to manage that constant pressure, it lowers the pressure when clients exhale. Bronchoscopy, if we have someone who has inhaled a piece of meat down their left main stem bronchi, probably they're going to need to have that removed. And that's what a bronchoscopy does. Okay? It's just a procedure that a physician does to go in there and remove it. So what do you think? Okay, have to have a bronchoscopy. What's your nursing? What are you going to do as nurses?
Well,
I'm going for a bronchoscopy. What are you going to do for me?
They're going to be NPO. And you're going to teach them.
How do you know it's me?
Oh, verify the patient.
Don't
Verify the
forget
order.
the basic stuff. You're going to identify, you're going to explain the procedure. In all likelihood, if it's down the left main stem bronchi, there's not going to be much time to talk about that. But I've still got my right lung, right? So part of your nursing responsibility, anytime anybody has a bronchoscopy, am I just going to, what about my gag reflex? Am I not going to vomit? Right? I am, right? Unless you anesthetize the back of, the back of my throat. So if you've anesthetized the back of my throat so I don't vomit, what am I also not going to do?
Swallow.
I'm going to swallow. It's not going to stop my swallowing.
Well, you're not going to gag.
But it's not going. I'm not going to gag. Okay. So if you have a client who's had a bronchoscopy and you have anesthetized their gag reflex, are you going to go in there and remember my little sip of ginger ale, my ice chips? Okay. Have to make sure their gag reflex is returned before you give them anything by mouth because they can aspirate, right? So that is what, when we talk about atelectasis, that's what we're talking about. A collapse of any part of the lung field and there's not adequate gas exchange, right? So we've had this lovely strep epidemic in our little class. We've had upper respiratory infections in our class, and some of us have had lower respiratory infections. We're going to talk about those today too. Acute tracheobronchitis, what do we mean by tracheobronchitis?
Inflammation of the trachea and bronchi.
And the bronchi. Okay? What is acute? Sudden onset, right. And what is chronic? That's a long time. Okay. And it's not uncommon with an upper respiratory infection to get tracheobronchitis if you have a compromised patient. But the real problem that we have in hospitals and we have in our population is pneumonia. Okay? We have community-acquired pneumonia, which means someone comes in off the street and they've got pneumonia and we don't know where they got it. We have hospital-acquired pneumonia, which means you came in for your knee surgery and got pneumonia. Okay? We have pneumonia in an immunocompromised host, which means you came in with lupus and you got pneumonia. Okay? Any sort of problem with your immune system, you come in, you're immune compromised. Well, is everybody in the hospital immune compromised? Why? Because they're under stress, and stress compromises your immune system, right? But typically when we talk about pneumonia and an immunocompromised host, we're thinking about clients also with HIV. They're immune compromised. Anything that compromises your immune system. What else? What do we do to clients? What do we treat that causes compromised immunity? What do we treat?